Hi all, my name is Eli Snow and I'm one of the Critical Care Outreach Sisters, and I'm here today just to briefly go over for 5 minutes the role of the Critical Care Outreach team at Barts Hospital. So first of all, who are we? Well, we're a team of experienced nurses and physios. We've pretty much most of us worked in intensive care, but some of us have come from other acute wards. And we do love a bit of excitement and drama, so please don't hesitate to call us if you're worried about a deteriorating patient. Next of all, what do we do? Well, our primary job is clinical, so we primarily assess acutely ill and deteriorating patients. Our referral criteria for this is NEWS of 5 or more, and this is as per the NEWS 2 national guidelines and local policy, which you can see here, NEWS of 5 or more, or 7 or more, which is medium and high risk. They both state to refer to CCOT. We also attend all 222 cardiac arrest calls and medical emergencies. And finally, our other referral pathway is all ITU step downs. This is excluding all cardiothoracic patients who are on the pathway, but all other patients who step out of ITU should be referred and seen by CCOT within 24 hours. So assessing deteriorating patients, what do we mean by that? So all of us can complete an advanced A to E assessment of a patient. We generally support the primary medical team and nursing team in their assessment, investigations and management of deteriorating patients. We can help them with levels of care, so 0 to 1 would be a ward patient, whereas 2 and 3 would require higher levels of care. And therefore we can help them decide whether the ward that they're currently on is appropriate for their required care needs. We give a general ITU perspective, so whether a patient requires higher respiratory care, for example, Optiflow, CPAP, non-invasive, and again, if they need inotropes, and specifically which inotropes would benefit that patient. We help with complex fluid management and electrolyte replacement, and again, when these can be managed appropriately on the ward or whether they require ITU care. We also liaise with teams regarding ceilings of care. This technically shouldn't really be part of our job, but it is quite a big part. So liaising generally with the primary team and ITU to kind of set ceilings of care and discuss appropriateness of ITU. And finally, we also transfer acutely unwell patients either to investigations such as CT scan or to ITU. So generally, if you have a patient that's been referred to the intensive care unit, we will generally always be involved with that patient. So feel free to liaise with us because we will generally be with the patient. We can tell you how time sensitive that referral and transfer needs to be. We can also, if need be, start stuff on the ward and stay with the patient and therefore kind of create an ITU bed while waiting for an ITU bed. And generally the aim of CCOT is to intervene early in order to stabilise and improve deteriorating patients so that we keep them at ward level and they don't have to come to ITU. However, if that isn't possible and the patient does require intensive care, then obviously we try and ensure that there's timely referral and admission to ITU. So what also do? We do lots of non-clinical stuff. So we do lots of education. So this is both formal, we do teaching on formal nursing programs, and we also do informal teaching, sort of ad hoc on the ward and things like that. We're also involved in audits. We do multiple audits. An example of this is the NEWS compliance audit or the audit of our CCOT activity. And finally, we also, along with resus and the intensive care team, review all 222 cardiac arrest calls and medical emergency calls that get put out through the hospital to look at whether these need further investigation and to be highlighted and to see if there's any general themes that emerge. Now, importantly, what we don't do. So obviously, we're all nurses, therefore none of us can prescribe. We also are unable to order any radiological requests, such as chest x-rays, CT scans. We're also unable to insert art lines, central lines, PICC lines. We cannot accept patients to ITU, so this would go through the 6A consultants or the intensive care consultant for the particular ward. Again, we are nurses, we are not the intensive care medical team. And also, we do not take over the care of that ward-based patient. That remains under the primary care team. We are more of a complementary service. We are there to help and assist. And finally, the most important slide is how do you contact us? So we have a bleep and a mobile. We are available 24 hours a day and 7 days a week. And this is our bleep, it's 0264, and there's our phone number. But also, if the patient is being referred via the ITU pathways, just be aware that they're slightly different depending on the patient. So cardiothoracic patients generally go to the anaesthetic SPOC, and they would go to the first floor. And then all other specialities would go through the 6A registrar and the 6A consultants. And the bleep is there. Thank you.